These are the topics we'll try to cover in our hour. We are not going to be doing an Elder Abuse 101 today, but we'll try to take a deeper dive into the role of healthcare systems, specifically in identifying and responding to abuse. And we want you to feel comfortable unmuting, asking questions as we go along, put questions in the chat, use the Q&A, raise your hand, so that we're here to really meet your needs. So this is a definition of elder abuse that we use at the New York City Elder Abuse Center. We don't place as much of a focus on the elder abuse cases involving complete strangers. For example, an older woman is at an ATM and someone, knocks her down and steals her purse. It's the cases where there's day in, day out humiliation, there's manipulation, there's shame, there's fear. Cases we're talking about family members, perpetrators who know the victim, who have the trust of the older adult. These are the cases that we're talking about and that we work on at the New York City Elder Abuse Center. So you all know the types of elder abuse. Financial exploitation is the most commonly reported type of elder abuse, and even still in New York State, it's only 1 in 44 cases of financial exploitation that actually come to the attention of law enforcement or adult protective services or victim services. That number is 1 in 24 cases that gets reported for all forms of abuse. So we look at abuse as a silent epidemic, and even more so during the pandemic, as you can imagine, with mandated staying at home, isolation, the loss of many, many jobs, religious services that were shuttered, senior centers that were shuttered. But luckily, we're all working to get older adults vaccinated and keep older adults connected. It's important to note also that these types of elder abuse co-occur. So if an older adult's money is being stolen by, for example, their adult daughter, how do you think the adult daughter is getting access to the money? Most likely there's threats to hurt the older adult or hurt the older adult's beloved poodle or prevent the older adult from seeing their beloved grandchildren. There's probably manipulation taking place or worse. So just to note that if there are red flags for one type of abuse, we need to screen for other types. Many professionals ask us whether self-neglect is considered as elder abuse as part of the definition. There are many state statutes that do include self-neglect in their response to elder abuse, and it is a very large portion of an adult protective services caseload, for example. There's also evidence that self-neglect is related to other forms of abuse, whether it's a consequence of the forms of abuse and victimization, or whether the self-neglect creates a vulnerability in the older adult for which an abuser might take advantage. However, because self-neglect does not involve the relationship of trust covered under the definition of elder abuse, it is not considered a form of elder abuse in itself. And so we're talking about elder abuse definitions and prevalence, I just want to talk briefly about working with underserved populations. And as SUNY Downstate is located in Brooklyn and has offices throughout the many diverse parts of Brooklyn, this information should be of value to you all. About 20% of older adults are members of underserved populations, but in general, there's very little research about elder abuse and even less research about elder abuse in these populations that has been done. 2 studies that are of note, one 2014 study that indicates that African-American older adults are more likely to be financially exploited than their Caucasian American counterparts, and one 2012 study indicating that Latinx immigrants, report being abused 40% of the sample reported being abused in the past year. And that rate is much higher than the national prevalence for all older adults. And so the studies indicate that older adults from underserved populations need even more attention when it comes to identifying abuse, but quite often we as professionals don't seem to connect with these populations. Most of our outreach efforts rarely target underserved populations. Most of the research and the data that we are working with is about white people. And many institutions just don't take the steps to increase access to underserved populations. Additionally, the language that we often use when we even talk about and conceptualize abuse can cause a disconnect. There are different cultures, different generations who use different language to describe abuse and abusive actions. And we'll talk more about that. We'll talk more about that later. And then, of course, compounding that, Language and cultural barriers are correlated with the lack of access to technology, transportation, health services, healthy food, news that allows members of underserved populations to be aware of scams and risks to them, resources to help them stay healthy and protect themselves from harm, and access to services that can intervene if they are currently facing harm. So the takeaway on this is that we as professionals need to ask ourselves more frequently, who are we serving? Do our services acknowledge and meet the needs of underserved population? And if not, how can we better reach and serve underserved populations?
So the important role of healthcare. So really, we are on the front line. Evaluation by healthcare providers may be the only time an abused older adult leaves the home. So we have a unique opportunity to identify and evaluate elder abuse. They're much less likely to see their primary care providers, unfortunately, and they're much more likely to end up in an emergency room where, as you can imagine, the fracture will be dealt with, but the underlying cause that they were pushed and fell and fractured will probably go unnoticed. And so hospitals have a better opportunity to identify and intervene for obvious reasons. There are a number of different disciplines who are able to see the patient in different settings. The nurses may observe interpersonal relationships with family. Even radiation techs may hear things and see things that we may not see in an office setting. They're there for a longer time, so more opportunities to observe. And of course, there's resources available 24/7. So this is an incredible statistic. There is a threefold increase in mortality in abused versus non-abused older adults. And that's not from the trauma of the abuse, but more about the overall scenario that these people live in and day out, as Ayana very nicely outlined already. So there's all kinds of stresses, both physical, emotional, and otherwise, that are being put on people. And that takes its toll with a threefold mortality, threefold hospitalization rate, and of course, increased nursing home placement and depression and other mood disorders, post-traumatic stress, et cetera. So it has huge implications for the healthcare system. There are many a barrier to identifying abuse, right? Many of you are now getting some training. When I went through medical school, there was no training. I have tried to get more training into the curriculum at Cornell. It's not easy to even get geriatrics in, but it's getting better. But really, there's a widespread lack of training in how to deal with elder abuse cases. You can imagine the time frame, right? You're in the emergency room. You're seeing a patient who comes in with a fracture. You've got 6 other people to take care of at the same time. Are you really going to ask the questions that opens up Pandora's box about whether abuse is happening or not? Probably not. There's a very strong negative disincentive to ask the questions about elder abuse, and time is one of the big ones. Fear and distrust of the legal system. God only knows, you have to turn on the news now to realize not only the legal system, the law enforcement system, the medical system. There are a lot of injustices that are going on in the world right now. And it's not at all unusual for people to be afraid to bring in any kind of system into their home. Denial by the patient and him or herself, we'll talk more about that. Ambiguities regarding decision-making ability of the victim. Can they do, are they demented? Can they report accurately? There hasn't been, although there is now, much better in New York, a streamlined response once abuse was detected. And then finally, from the medical point of view, distinguishing what's abuse from accidental trauma or illness is not easy, even for me, and I spend a lot of time doing it. It's very tricky. So there's a lot of barriers.
I want to take a moment to introduce you all to this model. Has anyone seen this model before? I'm looking for raised hands or reactions. This is the abuse intervention model created by Laura Mosqueda. She's a professor, physician, director of the National Center on Elder Abuse. She's a rock star, elder justice pioneer and rock star, and created this abuse intervention model with her colleagues out of the Keck School of Medicine at the University of Southern California. There are a lot of frameworks that are designed to help us conceptualize. Oh, I see. Is that a raised hand?
Yes, I was just wondering, I don't know why. Are you pinned? Because we can't see, the model is super teeny, and I'm wondering.
Hmm.
I can see it. I can see it well. I'm not sure. Is that for everybody?
No, it's a
That's
fine.
better what you just
No, we
did.
could see it.
Oh,
It's
really?
better
And
what you just
did I
did.
do
There's a lot
something?
of black space above and below the slides.
Hmm.
But
But it's a little teeny thing for me. I maybe
No,
I'm
it's
just
a,
not.
it's a pretty
no.
good size.
It may be that it may be that your Zoom window may be minimized, so you may be
Oh,
seeing
I
just
just
the.
did something. I just did something. Great. Never mind.
I know the feeling.
Okay. Yeah, so there's a lot of frameworks out there to design to help us conceptualize the dynamics, the risk factors of elder abuse. But Laura Mosqueda created this framework really to be applicable to all forms of elder abuse and to help us conceptualize the risk factors in a very simple and practical way. So when we assess the risk of abuse, we're looking at the following factors in three broad domains. We're looking at the vulnerable older adult themselves, the trusted other, and the context for the abuse situation. In the context of this aim, the term vulnerability is defined as financial, physical, or emotional dependence on others, or diminished capacity for self-protection or self-care. When we look closely at the older adults and their risk factors, we are considering, of course, their physical function. As we know, physical impairments may reduce their ability to manage their activities of daily living and may increase dependence on others for additional supports, additional care. The older adults' mental health and their cognition, absolutely, yes, impact their ability to manage their activities of daily living, but also affect their judgment, also affect their insight that help protect against something like financial exploitation and assessing who may be trying to harm them and whether what is being done is in their best interest or not. When we look at the trusted other, and by trusted other, we're talking about friends, family members, neighbors, caregiver, could be a financial advisor, any individual who has the trust, who's involved with the older adult who could potentially cause harm. And we're also looking at their mental health, personality traits, like emotional distress. We're considering if this trusted other has untreated mental health conditions. Are they bipolar and they're not receiving treatment? Do they have mood disorders? Are they experiencing caregiver frustration? Is there substance abuse occurring? These factors all increase the risk of abuse and affect the trusted other's ability to support the older adult adequately if they're in a support role. Then we also look at whether they are dependent on the older adult for some reason, whether it's financial support or emotional support. That kind of relationship of dependence on the older adult can result in conflict, can result in hostility, can result in resentment that can cause an abuse situation. Finally, we look at the context for the situation, which plays an important role in either mitigating or exacerbating the risk of abuse. And social integration has been a topic that has been on a lot of people's minds in the context of the pandemic. Social isolation has increased for many, not just older adults, for many of all of us in the community. And social isolation is a major risk factor for elder abuse when there's no one who's able to help the older adult when help is needed, or people who can help but don't even know there's a need for help, or when the abuser is intentionally isolating that older adult, which sometimes as professionals we can overlook that isolation is intentional. These, of course, impact the risk of abuse. We also look at the quality of the relationship between the older adult and the trusted other. A low quality relationship might sound like, the trusted other is not willing to listen to the older adult when the older adult has a request, needs someone to trust, needs emotional support. That low quality relationship, of course, increases that risk of abuse. And finally, we're looking at culture. So back to the point about underserved populations and trying to understand and be more responsive to the needs of underserved populations. Culture, consider cultures of self-reliance, where there may be shame about particular illnesses like dementia. So the trusted other, the older adult themselves may not want to reach out for support because they have shame about what the family is experiencing. Or consider cultures where the male is the head of the household, manages the finances, takes care of the family, and can do no wrong, even when they are doing wrong. So these are the factors that we look at as far as assessing the risk of abuse, and we keep this aim in mind to help us determine which of these risks can be mitigated with support services or interventions as well. So if, for example, the older adult is in a wheelchair, she's got diminished physical function, she can't transfer independently in and out of the wheelchair, she cannot bathe herself, she depends on her adult son, for example, to help her with bathing, but the adult son is very uncomfortable with bathing his mother, and in their culture, and a child just does not see their parent nude. And so he's just not bathing her at all. That's the risk of abuse, of mistreatment there. So that risk of the neglect that could occur from a situation like that could be mitigated with personal care, home care services potentially. So this model helps us not only identify the risk factors, but then identify which of these risk factors could be influenced or mitigated with an intervention. So good to keep in mind. Ryan, you're muted.
Sorry about that. So I'm going to talk a little bit more now about forensics. Thanks, guys. And again, getting back to Laura Mosqueda, Laura did one of the really groundbreaking studies way back. This is years ago, but still holds. Looking at older adults who were bruised in long-term care facilities. And some of the things that she came up with, she observed the skin of these individuals for like 100 days consecutively. And what she found in her study was that inflicted bruises were larger, it's not surprising, usually more than 5 centimeters, that you were unable to stage the age of a bruise by color. Now you may say, who cares about that? In the world of forensics, trying to figure out when someone might have been hit, it is actually of import. And what she found was that we usually think young bruises or bruises that just happened are more purple and over time become yellow. And I would say in general, that's probably true, but she really did see that sometimes on day 1, bruises were yellow, and way out in day 10, they were still purple. So you can't stage a bruise by its color is the moral of that story. And then finally, that location of accidental bruising was more often on extremities, and that makes sense. Think about our older adults who are on wheelchairs, who are knocking their shins into their foot holders, etc. So people who were abused were more likely to remember the cause of their bruises, even if they were mildly or moderately demented. So please don't hear the word demented and then automatically dispel what an older person with mild cognitive impairment is saying about how they were abused. I did a project at Cornell with an associate of mine in the emergency room, Anthony Rosen, he's rock star number 2 in the world of elder abuse. He's done an amazing amount of work. And what we did is we were able to access the legal files of 100 prosecuted elder abuse cases in Brooklyn. The DA's office allowed us access to those files. And in those files were a significant amount of medical evidence, pictures, photos, and the scenario in which the abuse not allegedly did occur, because these cases had already been prosecuted. And we did a meticulous taxonomy of the injuries, how big they were, what the color was, their exact location, et cetera. And we compared those injury profiles with 100 patients that came into New York Presbyterian emergency room with real falls, accidents, not abused. And what did we find? We found a lot of what was already in the literature. And so let's go over that. Head and neck injuries for years have been known in interpersonal abuse, domestic abuse. Head and neck injuries are always worrisome. The left periorbital area, so if I were to hit you as a right-handed person, which most people are, and come and punch you, I would hit your left periorbital area. So a left black eye is suspicious. But what's more suspicious would be a left black eye in the absence of any other bruises on the extremities. So if you fall and you hit your face and you get a black eye, you probably put your hands out, probably scraped your elbows or your knees on the way down. If nothing else is on the body but a left periorbital or a left black eye, that's a very, very high suspicion. That was statistically significant finding. Other areas that are suspicious: the nape of the neck, ears. There is a defensive wound, which is being hit in the ulnar area as you put your arm up to prevent someone from coming at you and hitting you. So any fracture, by the way, if you fall with outstretched hands and you break your radius. That's the way the bones of the forearm and hand are put together. It's very rare to have a fall with outstretched hands and break your ulna. So our radiologists actually consider the ulna a suspicious fracture. Bruising in various stages to indicate abuse over time, over months or weeks. And there's a variety of other areas. So the torso, head and neck are more suspicious than the extremities. And I think that's the basic take-home message. But these areas here would all be considered a little bit suspicious. Let me just say, obviously, any bruise can be accidental, right? So, this is not hard and fast science. This is just generalizations based on a lot of observation. But, you can explain away almost any bruise. Okay, next slide. So I'm going to take you quickly through some pictures. These are somewhat slightly upsetting, to say the least. So please bear with me, but this is a medical audience, so we'll go through and show. So here's a bruise to the ear, the pinna, and that would be considered very unlikely to happen from a fall. Is it impossible? No, but considered unlikely, probably from someone's ears being boxed. Next. Here's patterned injuries, okay? On the right might be a belt buckle or something, an implement of some sort. On the left could very easily be a bite or fingers from being grabbed, but you can see there's a definite pattern to those, and you'd have to hear the story to understand what might have happened there. But patterned injuries are of concern. Ligature marks, so this is a classic strangulation mark. Obviously, you can see the swelling of the hyoid bone in the front there. You can see clearly there was a rope around the neck. What might a person present with? Their nose may be up in the air trying to, it's called the sniff response, trying to straighten out their trachea and get air in of a trachea that may be compressed by soft tissue swelling. They may have stridor. They may have perturbation of the carotid arteries and present with a stroke. Those are, and they would be hoarse. They would be hoarse when they try to speak. Next slide. And this is the classic finding of petechiae in the conjunctiva. You would also see that under the tongue. You would basically see the petechiae anywhere from the point of ligature upward. So that is a very classic finding in strangulation. In the wrists and the ankles, these are ligature marks from being tied down to keep someone from either being annoying. We have a lot of older adults who wander. Sometimes families do this not so much to be in a nefarious way, but because they just are at their wits' end and they don't know how to keep the person from walking outside in the middle of the street in the middle of the night. But most of the time, this is just someone who's being tied down because the family just can't deal with them or are trying to punish them or whatever. But pretty terrible, no matter how you look at it. Burns occur very commonly. They're usually because of abuse, or because of neglect by caregivers. 20% of geriatric burns are residents of a facility and they're demented. So you can imagine the scenario, you're in a nursing home, you see the person serving someone a nice hot bowl of soup, they put it in front of them, the person is very demented or has Parkinson's or has other issues, and then they leave them there. And of course, that soup ends up all over their chest and lap and thighs, and they get very bad burns, usually with a very high total body surface area affected and resulting in mortality. There are also immersion burns. These are clearly burns that were done to harm someone. I'll show you a picture in a minute, and you can see a very clear line where the person was basically dunked into a hot tub, and they're awful and have very, very bad outcomes. And then there are other burns like with irons that are, objects you can clearly see, or from cigarettes. Next slide. So on the left, you can see an immersion burn. You can see the very clear line of demarcation where someone was basically dunked into hot water. And then on the right here, this is a classic cigarette burn, which, is just awful. Sexual abuse is thankfully rare. If you were to list the abuses in order, it would be neglect, self-neglect, financial abuse, psychological, physical, and happily sexual last. And these are some of the classic findings. I just had a case like this that I'm consulting on. I do some expert witness work, and it was these exact kinds of inner thigh bruising, which is, if you think about it, very hard to get in any other way other than having some force by hands on the inner thighs. And then you can see there's some fissures, erythema petechiae of the labia, and redness in the vaginal and vulvar area. So when we talk about neglect, the two most common things that we see are malnutrition and dehydration. I think most of you have probably seen somebody with neglect that has shown up in the hospital. And so those are extremely common. If you look at ME data, those two causes are overwhelmingly the things that they list as cause of death. But other indicators, poor hygiene, if they come in without their dentures, glasses, hearing aids, walkers, etc., that's neglect. Extensive pressure ulcers, we'll talk about that in a minute. Rashes and excoriation from people who have been left in their adult protective diapers for a long time and don't get their proper hygiene, fecal impaction, and then if someone comes into my office who's usually been very well controlled with their hypertension and diabetes, and they come in completely decompensated, not taking their medicines, it makes me wonder what's going on at home. These are demented patients, obviously. What's going on at home, and why are they not getting what they need? Okay. So what are suspicious pressure ulcers? Again, when I work with a lot of lawyers who prosecute these cases of elder abuse or neglect, they say there's this pressure ulcer, this must be neglect. Well, no, I know, we know that pressure ulcers can occur even with the best of care. So the ones that I worry about are when there are multiple. So I give, if you're an older adult and have advanced dementia and you have one pressure ulcer on your sacrum, I'm not going to start calling the DA's office. However, if you have multiple pressure ulcers in areas that should be easy to protect, that are dirty and untreated, that have not come to the attention of a doctor or a visiting nurse or some health professional, that are quite advanced and infected, and that perhaps are surrounded by rashes that look like they haven't gotten any kind of hygiene, where there's lack of documentation of turning or positioning. I'm talking now about nursing homes or nursing homes. If they haven't been given the proper mattresses in a nursing home, and if they don't have the proper cushioning, et cetera, then I start saying, okay, this is a suspicious pressure ulcer. This might be neglect. It's a hard thing to really pin down. Next. These are some of the pressure ulcers that are seen by the ME, or sometimes even in our hospital come in. You can see, we don't even know how to stage these, right? But you can see the rashes there, and eschar on the right. And so, these are very advanced pressure ulcers that would make me wonder, and there's multiple. And here's another area, the outside of the knee. That person was probably left it. This is unfortunately a person who's deceased. This is a medical examiner picture, but this is, you can see that she's cachectic, and also that she was probably just left on that left side, God knows how long, and developed a pressure ulcer there. And just other signs of poor hygiene, right? No dental care, the nails are not cared for. Those should all be red flags for you. You should be saying, what's going on here? This is really, doesn't look good. Okay. And lastly, there are some other findings. So the CK you can look at either from somebody being hit, where there would be release of muscle enzymes, or more likely being left on the floor or left in one position for an extended period of time, where the CK would go up. The presence of psychotropic drugs or other drugs that were not prescribed in an attempt to sedate or harm would be worrisome. And the flip side of that would be the absence of drugs you did prescribe for chronic illnesses that were not present in the blood. So thyroid hormone, anticoagulants, seizure meds. If they're not there when you test for them, something is not right. These are obvious to all of you in the room: high sodiums, high BUN and creatinine, high uric acid, elevated hemoglobin, all speak to dehydration, right? So those are some things you'll look at. And then malnutrition, a low albumin or pre-albumin, low cholesterol. And these are some other esoteric findings: low transferrin, low lymphocyte counts. We don't really look at those that much. B12 and vitamin D, hard to really pin that on anything, but it might add to the picture, as well as anemia, but I would put those very low on the list. So we have to really think of neglect as a syndrome. It's not any one silver bullet. You need medical evidence, family, you have to look at family dynamics and structure. You have to look at motive, risk factors. Have they been involved with the healthcare system? And are there previous domestic incident reports or APS contact? I want to know all of that before I start saying that this is a case of neglect. I don't even want just the medical evidence. I want all of that, as much as I can get of it, before I can put together a full picture of neglect. Next. I'm going to skip this for the sake of time, but these are some of the common motives. Power and control is really the most common, but financial motives, they want the apartment, so they want grandma out of the picture. Long-standing family discord, I think, and caregiver burnout. These are some of the common things that we look at in terms of motive. Next. And then, as I said, lack of medical care, no visits to the PCP, no VNS, no physical therapy, no treatment for the pressure ulcers, all major red flags, not getting their treatments until 2 weeks later for the fracture. Those are all worrisome.
So, we've spoken a little bit about seeing indicators of either intentional neglect or maybe physical abuse in the hospital. What happens when you have a patient in the hospital who can't explain what happened to them, or maybe doesn't want to explain what happened to them? Someone who has dementia, someone who has an intellectual disability. They might not have, I think Ayanna mentioned earlier, insight into the potential abuse. There might be a heightened ability to be coached on their response by the alleged abuser. Studies show that almost 50% of individuals with dementia have been mistreated in some way in the past year. So, in the criminal justice system, often a lot is put on the individual who's considered the victim of the crime to explain what happened and be sort of the complaining witness. However, DA's offices have the ability to bring cases based solely on other evidence and not just testimony from the crime victim. So this really goes back to the importance of documenting as much as possible, really paying attention to the signs of what you believe might be abuse. We had at the New York City Elder Abuse Center have dealt with cases where the only eyes that have been on the injuries to the victim have been those of people who work in the hospital. Other things to think about when you're not sure whether a person has insight into their situation: what's their capacity level? So, most hospitals have the ability to do capacity assessments. A lot of times it has more to do with making healthcare decisions in the hospital or making decisions about discharge planning, but this can also give you some insight into what their insight might be into their own situation, and whether or not maybe further steps need to be taken. So let's say the case is also a case that you feel should be referred to APS because you think there might be abuse, you think the person might be at risk. At APS, they in New York City, we have psychiatrists through the Department of Social Services who are actually able to perform psychiatric evaluations and determine whether someone who's an APS client has the ability to understand what's going on with them and determine whether involuntary services might be necessary. Another tool that's at APS's disposal is the interview for decisional abilities. I don't know if Ron, you want to talk about that for like 20 seconds.
Yes, 20 seconds. The interview for decisional abilities was crafted for APS workers who are in the scenario of facing a client in significant risk who is refusing the service. How does that APS worker determine whether that person has the decisional ability to refuse the service? And I'll leave it at that and we can talk about it more.
Okay, thank you. And, using these psychiatric evaluations and what's known as IDA, interview for decisional abilities, it can again help determine whether or not involuntary measures might need to be taken, which could include financial management. The Department of Social Services has the ability, if someone's receiving public benefits, to sort of take those benefits and pay bills for them. But also a lot of times we're talking about guardianship, right? So a lot of cases where there might be abuse and someone doesn't have insight and judgment might be leading us to talk about guardianship. And we need to remember that the standard for guardianship is really high. And a lot of times people want to sort of toss guardianships at situations, but you need to be able to show that the reason someone's suffering harm is because they themselves can't understand and appreciate the risk that they're at. So it's a really high threshold. What I will say is that, if the case is within the New York Elder Abuse Center, we have been able to sort of accelerate the process by having all the people who have knowledge of the case come together, learn the information as fast as possible, and helped build a guardianship case. Another tool that's available through guardianship sort of more recently is that people can get orders of protection through the guardianship process and make it so a person either doesn't have the ability to talk to them, reach out to them, harass them, or physically be in the same space as them. And then of course, there's financial management, which can help protect a person from financial abuse, but I know that doesn't come up as often in the hospital context.
I see that Tanya has her hand raised.
This was a really wonderful presentation, but it of course makes me really sad because we know that so much of this abuse is going on and we're not detecting it. I love, in terms of this presentation for providers, really making our trainees aware that they could be that one person to be able to detect, and it's often with providers. Or people who are not providers, but people who are sort of in the clinic. I remember a woman was coming in for a study and she left her home aid attendant, and her own home aid attendant was furious at her, but she was just like, I have to get away from this woman. And it triggered sort of, well, let's look into this. Why are you trying to get away from your home aid attendant? But I wanted to just make two comments. One is that I believe is that Dr. Mortley mentioned the issue around sort of financial exploitation. And I know that there was another example around or a mention about housing and people wanting their older relative to leave. And I just wanted to add two little caveats to that in terms of for our trainees to think about. One is that there are certain patient populations that because of their chronic ailment, and so I'm an HIV researcher, and so part of the Ryan White funding also provides you know, really wonderful services in terms of support for housing, et cetera. And over time, I've noticed that a lot of our older women are becoming sort of vulnerable to these younger guys who want to basically move in because everything's being paid for. And so I'm not exactly sure if there are other patient populations that have sort of a similar disability sort of arrangement where that because of their assistance from the state or whatever, they become real targets. And I wanted to just say that sort of often those women that there was sort of a sexual sort of a sexual hook in terms of young men pursuing older women who are positive, knowing about their serostatus. The other thing that I wanted to say is that because of our housing crazy laws here in New York City, that in addition to, I guess what most people think is the classically like, I want to get into your lovely apartment on the Upper West Side, that what is also happening is that there are a number of women whose children are coming out of jails and prisons, and they immediately go home and you can't get them out. Because if you stay in an apartment for longer than 30 days, and I can't remember exactly the stipulation, but like you're considered a guest and like you can't get them out, which is really crazy. And I, during the middle of a study, we were sort of doing a visit in the person's home, but it wasn't her home. It was a friend's home, and she was staying there, and her son, who just got out, was basically terrifying these ladies. And so I think what is really important is for, I think, folks to understand what we do with this information in terms of being, you know, court reporters. Like we have to, I think that it'd be really important for people to know who to call. I'm not sure if there's something within our institution or if there's something sort of within the borough or whatever, if there's a police sort of, you know, unit that specializes in this, but that would be really helpful to be able to include that. You know, I know our residents who, I'm not a resident, our third-year medical students want to have all these phone numbers connected to their IDs so that they have them at hand. And I think we should probably do something similar, make a card with these numbers. I really appreciated this this lecture. It's horrific, but thank you guys very much.
Oh, you're very welcome. I think there's a couple of more little slides. Dina, are we?
Yeah, we can move on from this one.
Yeah, let's
And we can talk a little bit about resources.
Yeah, that if we go forward to that. Yeah. Yeah.
Sorry, Ronnie, where do you think we should go?
Yeah. Can I just say 2 words about photographs and documentation, and then we'll end up so we can take questions. So you know, again, you know, I sometimes consult with lawyers, and if we're going to put a case together for, you know, that's going to go through in terms of the legal system, and by no means do I want you to take from this that we're trying to prosecute every single family that comes in. But there are some cases that are so egregious that they should be prosecuted. But in any case, please, 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 for all the residents and physicians on the call, documentation is so crucial. And I'm talking about the size of the wound, where it is, and if you could possibly take pictures, take not only a close-up, because then we can't, like in this picture right here, if you look at it quickly, what part of the body is this? So, you know, after a while you can sort of figure out where it might be, but take a picture far away so we can see exactly where the injury is, then take a medium range picture, then take a close-up. because otherwise, and then always have something like a ruler or something next to the wound so you can tell the size of it for legal reasons. And document everything you can possibly do in your chart, what the person's mental status was, what were they crying, were they, so everything helps in a case of elder abuse. Okay, thanks. I don't want to belabor that point. Yeah.
So these are the numbers that folks should have. Luckily, New York does have a lot of agencies that can investigate reports of elder abuse and financial exploitation and neglect. These are typically the big three. Most of the time, if a professional identifies abuse, most of the time they'll refer to APS. APS has specific criteria. And so the bottom line with referring to APS is that they work with people who have cognitive impairment. So people who may have dementia, diminished capacity, other mental health conditions, physical health conditions, and people who are facing a risk of harm and do not have anyone else who can assist them. They are luckily, well, maybe not luckily, but they are the only mandated reported to law enforcement in New York State. New York State is one of the very few states that does not have the mandated reporting laws related to elder abuse and abuse of adults. But they can provide involuntary services for clients who have diminished capacity, who have cognitive impairments. And that could be something like financial management for financial exploitation cases to stop the financial bleeding. And as a last resort, as Dina said, guardianship can be facilitated through APS. Department for the Aging actually contracts in each of the 5 boroughs of New York City with a elder abuse prevention and intervention organization. Their services are for people 60 and over, voluntary services, so the older adult has to be self-directed, able to collaborate as part of the intervention plan. There's a phone number there. And then you have us, New York City Elder Abuse Center, and again, we're a resource for you as professionals. So if you have questions about how to safety plan with the patient, what the best next steps are, how to go about interviewing the patient to uncover whether there is abuse, if you need assistance accessing a system that you've been having trouble accessing, connecting with an organization who could intervene in this situation, but you have not been able to connect with them. We provide that resource, that support to professionals. Dina, do you want to add anything to that?
No, I want to be able to have 1 minute to explain about what the teams are.
Yeah, please do.
Great. So the number that Ayana mentioned, where you can have case consultations with the New York City Elder Abuse Center, if the case is particularly complex, we will move the case to be presented at an elder abuse multidisciplinary team. And I know we're talking about Brooklyn. In Brooklyn, I facilitate those teams and we have them twice a month. So on these teams, we have professionals from all different fields with experience in elder abuse, family violence, who meet regularly and develop interventions, and then we track the cases over time. So we usually don't hear a case once at the team. We follow up a couple of times until we feel that risk is mitigated. So the slide that you're seeing right now shows the systems that are typically at these teams, and we have Ronnie as a geriatrician who is on many of the teams, and we have geropsychiatry, APS, Department for the Aging, DA's office, civil legal services, NYPD, community organizations like Womankind and JASA LEAP. We have elder abuse shelter programs, victim-centered programs for victim services, and we have access also to forensic accountants. So through all of this, we can really look at a case from different angles, figure out what can be done, what needs to be brainstormed, and really be person-centered and present all potential options to this individual that's experiencing abuse so that they have every resource that all these people that are at these meetings can possibly come up with. So if you call that number, which we can show you again or say again at the end, I don't remember it now, you can be connected to case consultation that can link you to these teams. And are these, yes, so there's a question, these meetings are open to anyone who has a case to present. It is a little bit of a system where we have core members who we try to have every single discipline represented and not duplicate it, because we work really hard to create relationships between everybody at the meetings. So if you have a case that you want to present, we are, welcome to have those cases come to present. If you want to talk in the future about potentially observing the teams, it's a little bit of a different situation. We've had people observe in the past as a specific educational opportunities, or if people are trying to start teams themselves. But if there's something that you're very, very interested in, just, definitely reach out and we'll see what's possible.
Yeah, I think the bottom line is that you as professionals may be the first person to get eyes, and that older adult to get eyes on the injury, to have the suspicion that abuse is occurring, but there is no expectation for you to be able to make a bunch of referrals, facilitate the intervention, provide support to the trusted contact and the older adult, and follow up. There's no expectation for any of you to do that. It absolutely does require, because these cases are so complex, collaboration. So you need us, you need APS, we need the domestic violence unit of the NYPD to do wellness checks. We may need the district attorney. So our role at NYSEAC is to connect you and to make sure that that older adult is getting the intervention that they need, that is centered for their specific situation. Our partners are APS, are all the folks on that slide, and we don't expect you to do it alone. So if you just have a hunch that someone is being mistreated, call us. That's really the bottom line. And so I think it's comfortable if we stop there. I know we're already over time, but I'm happy to stay on a little longer to take questions if there's questions.